Welcome back. We are going to continue talking about restraint and chemical sedation in the context of the agitated pediatric patient. Today we are going to look at the more high-risk situation where verbal de-escalation has failed and the child is becoming a danger to themselves or a danger to others. Before I continue, let's just recap. Welcome to my channel, Small Kids, Big Emergencies. Today we'll be talking about not so small kids and big mental health emergencies. The single most important takeaway message here: any form of restraint is always a last resort. There is almost always an alternative. Visit the Restraint Reduction Network to learn more. Before we begin, this is a large topic. Please be aware of the wider literature on this topic. This talk does not replace your local policies or guidance. It is an attempt to summarize a few principles on the topic. So last time we talked about Plan A, how to verbally de-escalate a young person. This is always the best option. But what if they become a danger to themselves? What if they are a risk to others? If the risk becomes high, then consideration needs to be given to Plan B. Consider, is there actual risk of harm? Is the danger imminent, or is there time to consider options? Are there other options besides restraint? Is discharge a safe option that would de-escalate matters? If all other options have been exhausted and there is an immediate danger, restrictive options need consideration for safety. Healthcare staff at large are not trained in restraint, but they may be involved in a team with trained professionals such as security or indeed police. Certainly, those who work in mental health care settings may have additional training. In either regard, the focus here will be the decision making and not the restraint itself. It is worth noting that restrictive options include a range of actions, not simply physical restraint. Realize that all actions shown here represent restraint in some form. Again, the underpinning principle is to always use the least restrictive restraint possible. In doing so, harm will be minimized. The first question to ask is whether the situation is a true emergency. Is threat to life imminent? If there is no threat to life, it is not an emergency. If the threat is not imminent, it is not an emergency. Of course, there is a great deal of clinical judgment required here. Using "it was an emergency" as justification for restraint mandates 1. The absence of time for other considerations, 2. The level of risk to be high, and 3. It to be in the person's best interests and the interests of others. If it is not a true emergency, then there is more to consider. This approach is supported by NICE guidance. NICE advocates for discussion and consultation whilst adhering to best practice guidance. Ideally, you should gain the agreement of a second professional, and both professionals should be suitably positioned in seniority to make the decision. Furthermore, all decisions are dynamic and bespoke to the situation, which may be either escalating or de-escalating. It is preferable to have "if X happens, we will do Y" in place proactively rather than reactively. Bottom line, if a decision is taken with the express purpose to preserve life, it is largely legally defendable. Take a minute to understand this point. A further question is whether the patient, the young person, can simply just leave. Now we need to consider the following. Are they competent to make that decision to leave? If over 16 years, have they got capacity? If under 16 years, do they have Gillick competence? Legal frameworks that apply here are shown below. First of all, the Mental Health Act. This is a little bit subtle. The Mental Health Act does apply to under 18-year-olds. A 15-year-old can be detained under the Mental Health Act if criteria are met. However, typically, this is not the justification in the immediate sense to stop them walking out of A&E. The reason for this is the use of the Mental Health Act requires time. It requires a proper assessment, approved mental health professionals, and doctors with appropriate sectioning powers. This process takes time. So in the immediate emergency moment, you are instead relying on common law. And then if restraint and stopping them leaving is required in a longer term, transition to the Mental Health Act is required if ongoing detention is required. On the whole, there are a few instances where children over the age of 16 are safe to leave, and there are almost no instances where children under the age of 16 are safe to leave. We will discuss some cases shortly. Let us consider a 17-year-old. Capacity is always decision specific. We are asking whether they have capacity to decide whether or not they should be accommodated in your department or hospital for the purpose of being given further assessment, care or treatment. You need to understand their views. What are their reasons? What is their understanding? Are they cognitively able to absorb, retain and weigh up the information you are giving them? Are they able to communicate their decision to you? Ultimately, the question is, do they have the mental capacity to make an informed decision about leaving and refusing care? Remember to optimize communication. Consider communication aids, interpreters, an independent mental capacity advocate. Think about the time of day, think about the context of the assessment. Have you optimized communication? Principles of best practice here include, if in doubt, assess the person's capacity. Listen and involve others who know the person well. Avoid assumptions and prejudice. Make reasonable adjustments and record any assessment made. The flowchart exemplifies the process further. Make sure all reasonable adjustments have been made to optimize communication and understanding. Again, is the person able to retain relevant details? Is the person able to use the information to make a decision? Is the person able to communicate the decision? If the answer is yes to all, then they can be deemed to have capacity. Of course, capacity alone is not sufficient justification to allow someone to leave or refuse treatment. Let us again consider a 17-year-old who does not want to wait review by the mental health team in A&E. Perhaps he has disclosed his self-harm, cutting, as a form of release and self-regulation. Perhaps his mental state exam is normal, including his understanding and cognition. Even a child who has capacity and is competent to make decisions, who is over the age of 16 but wishes to leave, is a complex situation. Consider, is there any immediate danger? Is there any necessary physical treatment? Are there any concerns of an acute mental health condition? And importantly, are there any safeguarding concerns? Are there any parental objections to them leaving? If they have capacity, there is no danger, there is no concerns of an acute mental health condition, and there are no safeguarding concerns, ideally with parental agreement, then there is no legal justification for them to be kept in hospital and restrained against their will. Of course, the self-harming behaviour is far from ideal, and best practice still dictates that you discuss follow-up options and risk mitigation with the young person. You would still refer to community mental health services and discuss with your safeguarding teams appropriately. You would not, however, be justified in restraining them against their will in A&E. If any single element failed, if they did not have capacity, if there was immediate danger, if there was concern of a mental health condition that put them at immediate risk, or if there was a safeguarding concern that put them at immediate risk, then keeping them in hospital would be justified. What about a young person under the age of 16? What if they want to leave? Can they give consent to leave? Can they refuse treatment? Here we need to ask, do they have Gillick competence to make a decision? Key principles for assessing Gillick competence include consideration of age and related understanding with regards to the implications of any decision. Avoid undue influence or pressure that might be coercive, and recognise that the child themselves may have strengths and weaknesses in terms of decision making. Are they able to communicate understanding? Can they demonstrate retention of the information? Can they communicate and weigh up the pros and cons, and finally communicate their decision to you? Clearly, like before, there are multiple elements that can assist a child to lift their ability to consent. It is important to regularly consider the child's needs, revisit their preferences, and re-engage in their assessment during their care. Besides actual age, we should consider their developmental age, their cognitive ability, any emotional factors, relational factors, for example, being triggered, and of course, personal factors that make them who they are. Unlike before, where the starting assumption is that the person has capacity, here the assumption is that a child under the age of 16 is not Gillick competent until proven otherwise. Importantly, whilst capacity and Gillick competence are important elements of decision making, the decision to restrain is not simply the absence of a child's ability to consent. Yes, it informs the clinical decision making, especially when it comes to their ability to remain safe, but it is only ever a part of the puzzle alongside other legal safeguards. In the circumstances of a mental health attendance to A&E, it is almost always the case that there are safeguarding considerations that prevent the young person from simply leaving of their own free will. I can tell that this can be a challenging topic. Let's consider a case. This case is entirely fictional. Naz is a neurodivergent 14-year-old. He has impulsively taken a paracetamol overdose with intent to kill himself. He has mild learning disabilities and autism. His mother has brought him to hospital. His mother has had to leave to collect her other children from school, but will be back soon. Naz is refusing treatment. We know the amount of paracetamol is life-threatening. We optimize communication and use verbal de-escalation, including discussion of his fear of needles. Regardless, he is completely overwhelmed and dysregulated by the noisy environment, bright lights, and multiple people, and says he is going to run out the door into what is busy traffic. He understands the risks of his paracetamol overdose. He even communicates it back to you and explains his decision. Can Naz leave? Is he allowed to make an unwise decision? What if he wants to run home to his bedroom? Ultimately, a child under the age of 16, with or without Gillick competence, is not able to refuse care in this instance, and if he tries to leave, proportionate restraint would be justified. This is because whilst a minor can consent to treatment, they cannot refuse it if it is in their best interest and it is life-saving. Exactly what restraint should be used is another more challenging question. In this case, verbal de-escalation and reasoning would be ongoing. Context would matter. Is the mother a calming figure who will be back soon? How long is it until the mother returns? Are there other strategies like environmental modification? In terms of risk assessment, again, this would be highly dynamic and contextual. If we removed objects from the room, might things be safer? If we provided ear protectors, might we lessen his risk of head banging? What is his history of violence? How impulsive is he? With respect to aggression, how reactive is he? How proactive is he? Ultimately, it comes back to, have things shifted from disruptive without danger to disruptive and dangerous? For more about risk assessment, consider the following excellent video by a forensic psychiatrist. Scan the QR code now. The options we have available include all of the following. The more restrictive the intervention, the greater the justification required. Clearly, none are desirable, but the decision is about which minimize harm and achieve the goal of safety whilst minimally being restrictive for the least amount of time. In the longer term, where there is concern about an underlying mental health disorder that is either suspected or already known about, the Mental Health Act can also be used to justify restraint. Again, this is intended for temporary restraint and is not intended to fully deprive the person of their liberty. In addition, the Mental Health Act Code of Practice also stipulates that we must remove potential aggravating targets of aggression, use the least restrictive option proportionately for no longer than necessary, and continue to use de-escalation strategies. The Mental Health Act, again, has a place where things are not time critical and imminent. And the reason for this is it takes time for it to be applied. Parents, where do they fit in? In the case of restraining a person against their wishes, parental views matter, but are not paramount. Restraint to prevent violence, to prevent absconding, or to prevent them being a risk to themselves does not sit in the zone of parental discretion. It is a decision that a parent would not reasonably be expected to make. It is a decision that a parent might provide persuasive views on, but is ultimately not paramount. They may say, please don't hold him down, let me speak to him first. Physically holding his feet makes him very upset. If you hold him down for his safety, know that he'll try and escape as soon as you let go. Avoid that medication as it has bad reactions. In the past, he has agreed to oral medication. All of these parental views and information is valuable. The role of the parent will depend on the age of the child, the best interests of the child, and the type of decision being asked. Their role is important, but not decisive in determining the need for restraint. Equally consider if there are any issues that might undermine the validity of parental input. for example, where one parent agrees and the other disagrees, where they are distracted by distress and not able to focus on the child's best interests, where they themselves might lack capacity in decision making. So, are we indeed restricting someone when we restrain, or are we in fact depriving them of their liberty? To answer this, there are three questions. Is the person confined in a particular restricted place for not a negligible length of time? Question 2. Is there a lack of valid consent for this? Question 3. Is the state responsible for the confinement? For more detail, there is the Dole's Code of Practice. Remember, depriving someone of their liberty can be lawful if appropriate processes are followed, as per the liberty protection safeguards. To do so without due process is always unlawful. If all three criteria are met, it is likely that the act constitutes a deprivation of liberty. Further considerations include whether any harm to the person could occur if the act did not take place. What harm would that be? How likely would that harm be? What other options are there to avoid deprivation of liberty? If deprivation of liberty is currently unavoidable, what other action could be taken to avoid it in the future? Ultimately, the shift from restriction and restraint to deprivation of liberty is a one of degree, not nature. A person is objectively deprived of their liberty if they are not for a negligible length of time, and that part is crucial, subject to continuous supervision and control and not free to leave. The acid test is when we apply theory to practice. Let's consider the following scenarios. Momentary physical holding to stop a child running into a road that lasts seconds or minutes is most likely not deprivation of liberty because the duration is unappreciable. Equally, the occasional use of a secure room for brief cooling off periods, that is episodic and short term in a therapeutic context, is not usually deemed to be deprivation of liberty. On the other hand, continuous close supervision with doors locked to prevent leaving over days or weeks, where there is ongoing control, no freedom to leave over a sustained period, does constitute deprivation of liberty because it is met to the criteria appreciable time threshold. It is all about the degree, not necessarily the nature of the act. To summarize, in the emergency setting, we are always talking about restraint, that is as minimal as possible for the shortest amount of time. If the scenario is urgent but not emergent, then we need to be considering legal routes and rationales for the deprivation of liberty. Where the situation is not emergent but is instead urgent or even planned, how do we go about getting legal authority to acquire deprivation of liberty? Firstly, parents cannot consent to arrangements that amount to a deprivation of liberty for a child who is under 16 and lacks capacity, even if it is done in the child's best interests. For a child under 16, authority for doles is acquired through either a court's jurisdiction, e.g. the family court or high court, or under a mental health law framework, for example, section under the Mental Health Act 1983. Lastly, with regards to a child over the age of 16, the same is true with the additional justification available from the Mental Capacity Act if the young person lacks capacity. Okay, let's summarize. In order to justify restraint, we need to consider the following. 1. Is it in the person's best interest Is there imminent risk? 2. Is it necessary to prevent harm? Would they abscond otherwise? 3. Is the proposed restraint proportionate? 4. Would such restraint deprive the person of their liberty? To what extent and for how long? 5. Is there any alternative? And 6. Is there a second expert professional who is in an independent agreement with the need for restraint? In the circumstance where there is imminent danger, acting in the best interest of the person to preserve life is always the right course of action. Remember the principles, the codes of practice, and the Common Law and Mental Health Act in terms of justification. Remember, you are not Judge Dredd. Holmes, plan A, plan A, plan A. Verbal de-escalation is best. If thinking about plan B, prepare, prepare, prepare. Stop and think. Is what you're planning justified? Discuss with experts, ideally, and plan ahead. Ask, is it a true emergency? Is there truly immediate risk? Always think about your justification. Today's topic has been challenging. It takes work to understand these themes, and further study is advised. For those listening today, please remember that this video is for educational purposes only. It does not replace policies or procedures, and it does not take any responsibility for decision making in practice. I encourage you to keep learning together. Today we have talked about the justification for restraint. Next time we will talk about the how. Thank you for listening.